So Jeremy is the head of plastic surgery at Royal Perth. I've known him for a long time. He's a very good friend of mine, as is Helen. And he's also now the burn specialist at Fiona Stanley Hospital in Western Australia. He uses the full spectrum of plastic surgery techniques for acute and delayed scar reconstruction. And he's very, very interested in perforator and free flap surgery. Looks after patients with lower limb injuries, with complex diabetic foot, with head and neck cancer. So he's got lots of strings to his bow. And Jeremy is also the current president of the Australian and New Zealand Burns Association. So I'd like to introduce Jeremy to talk to us now about the acute management of burns. Thanks very much, Jeremy.
Thank you very much indeed, Alex, and we will get cracking with this. I'll just start sharing the screen. Hope everyone can see that. So thanks for the introductions, and thank you for this opportunity to talk about something that's very, very close to my heart, which is acute burn care. And as you've heard, I'm speaking all the way from this beautiful city in Western Australia, Perth, and I hope to be able to share with you some of what we do here in Western Australia with regards to acute burn care. As you've heard from Alex, I participate in a lot of acute plastic surgery, trauma and burns. These are really my interest areas: acute burn surgery, burns reconstruction, and as you've heard, I'm still very involved with a lot of other plastic surgery with regards to perforator flaps and microsurgical reconstructions, really across trauma and some oncology reconstruction as well. The top photograph there is where we have our adult burn service at Fiona Stanley Hospital, which is about 20 kilometres south of the city centre, and then Royal Perth Hospital, which is still mothership really with regards to trauma within Western Australia in Perth city centre. But back to the burns, and we run our burn service here in Western Australia out of two hospitals, as you've heard, Fiona Stanley Hospital for the adult patients, and the Children's Hospital in the western suburbs where the paediatric burn service is run. And really, like many of the burn services in Australia, we are responsible for looking after the entirety of the population from our state capitals, and of course Perth being the state capital of Western Australia, where we have those two burn centres. And from there we look after, of course, the majority of patients in our states that live in and around our state capitals, but we also spend a lot of time and a lot of resource looking after patients spread out across the 2.5 million square kilometres that is Western Australia. We do many of those patients, of course, in the metropolitan area, but really we have been using telehealth and video conferencing and all the technology that comes with that to help us look after patients not only in the metropolitan area, but really across the state. As you can see in this photograph on the left, you can see a demographic showing that a lot of our patients, of course, live in the southwest of our state and get our services in Perth, but we're also looking after patients from across the entirety of Western Australia. We have always used telehealth. You can see in this photograph, this is one of my patients at a hospital in rural and remote Western Australia, where we're able to look at digital photographs, speak to that patient about their scar management, whether that's surgical things, occupational therapy or physio. Increasingly, and I think COVID-19 has really driven us all to doing things differently and allowing us to keep patients out of hospitals. We can do so using a lot of technology, which we've adopted very, very quickly. This is a photograph of a patient's, I guess, backyard, quintessentially Australia. That was her background when I was consulting with a patient directly into that person's cattle station or home or whatever. So we've really been able to deliver advice and dressings advice and begin patients' care really very innovatively. Since COVID-19, I think it will drive us in ways where we can actually manage patients that don't need an operation. For example, in Perth, we can look after them very, very well, keeping them close to their homes and families and so forth using technology. And I think that will be applicable not only in Western Australia, but really anywhere in the world where you're watching this. So I'm going to talk about the challenges of looking after burns and why I think surgery is so important early on, and optimizing patients for surgery so that you can do early surgery, because I think it is vital to be operating on patients acutely. I'll give you some clinical examples of patients with small burns where I think this early surgical management is a clear winner, and I'll also talk about how we manage the larger burns or the massive burn injuries, and a little bit on specific burns where I think optimization of surgery and surgical technique is really, really important. The challenges, of course, with burns are what makes it attractive to people who want to do burns, because it's varied. Patients come with variable pathologies, lots of underlying pathologies which perhaps predispose to the burn injury, makes for a very varied and sort of challenging caseload. And of course, all of us who work in burns are very familiar with the different sorts of burns as well, whether it's scald injuries, chemical burns, but there can be associated trauma associated with those burn injuries, which adds to that level of complexity and makes it challenging in its own right, but also very interesting. The geographical challenges that we have in Western Australia are, of course, huge, but those geographical challenges are very real in any part of the world. And as I mentioned earlier, COVID-19 has really meant that all of us need to do everything we can to keep patients out of hospitals. And if we can monitor, if we can provide patient care, keeping those patients in their homes or out of their big tertiary centres, then that's not just an issue for Western Australia. There are, of course, finite resources. We're not all made of money. None of us have got much money now, seeing as the recession will very much hit us all very hard following COVID-19. But there are ways of making what resource we have cost effective. And I think early surgery is one way in which actually we can make acute burn surgery not only effective from an outcome point of view, but also from an economic point of view as well. And I think very, very importantly, we need to think about patient outcomes and along the way, how our patients experience their burn care. So we know that for deep burn injuries, fundamental to those patients' healing is early surgery. Early surgery is associated with better outcomes and, of course, better patient experiences. And for a deep injury such as this, it really is very straightforward and shocking to think that surgery wouldn't be a big part of this patient's care. And that's certainly the case for these injuries. These are extreme versions of patients with very, very deep injuries. These are patients of mine from Tanzania that have missed the boat, that have missed out on early surgery. And this is what we're trying to avoid at a very crude level. This is what we're trying to avoid in terms of operating on people acutely, because this patient has now missed the boat. Sepsis, inability to reconstruct these sort of defects mean that this sort of injury is now fatal. And that's what we want to avoid in our patients with burns. Operating quickly minimizes deterioration such as this and minimizes morbidity and mortality. But what about injuries such as these? This is a classic sort of flash flame burn that we see in young men who are keen on throwing petrol onto bonfires and onto barbecues and so forth. These might be described as indeterminate injuries, the mid to deep dermal injury. These are difficult in the fact that some of these perhaps will heal without surgical intervention, depending on exactly how they are treated. And some, of course, will need surgery. And it's really determining which of those patients require surgery. And that's something that I'll spend a bit of time doing now, because I think that the take-home message certainly from me would be that if there is any doubt about an injury such as this, then I would urge you to operate, providing the patient's ability, patient's comorbidities and your resource allows for that, because there are lots of pluses and lots of bonuses to getting someone with an injury like this healed quickly, as opposed to a long time in dressings. So what about early surgery and managing patients with burn injuries early? Well, if we look at outcomes, if you need surgery, then your survival in a massive burn injury is improved. And alongside that, your quality of life after you survive your burn is also better if you've had that surgical intervention done quickly. And we also know that the earlier the patients are healed, the better the scar outcome. That is something that many have spent time researching, and the evidence is very, very clear. The quicker you're healed, the better your scar. And of course, that has a better result in terms of long-term outcomes and, of course, quality of life. The side effect of all this early surgery and early healing are economic advantages as well. The patients are able to return to their jobs, to their lives. We're able to get patients out of hospital quicker. They end up with fewer complications along that journey. And so the side effect is very much an economic positive for early surgery also. But I guess the concern is if we operate on everyone, we're overdoing it, and we may well be. So you have to be careful in terms of your patient selection and making sure that patients that need an operation get an operation, and those patients that don't need an operation are appropriately looked after still. They're not discharged, but they're still looked after by an expert team of burn care professionals. Because unnecessary surgery may increase morbidity with regards to patients with pre-existing ill health. And of course, there are potential complications associated with anaesthetics and blood loss. So I'm not suggesting surgery for absolutely every injury, but bearing in mind that an awful lot of patients can be operated on safely, that blood loss isn't a must, and you can certainly put lots of measures in place to prevent unnecessary blood loss, and I'll talk about that shortly. But on the whole, surgery is something that surgeons and burn teams in general should not be afraid of. So what helps me drive the surgical decision? Well, I think it's experience, and I'm, as you've heard from Alex, I've been involved in burn care sufficiently long that both Alex and Helen were both my registrars and fellows, and it's great that other people have got that enthusiasm and have followed on and have become experienced and expert in looking at burns. So you get good at doing if you're doing burns, should be doing burns. Experience counts for a lot. If you look at this patient has had an issue with regards to wound healing. They've been very, very slow in getting an operation, and no surprises, poor graft take, and the resulting scar is poor. No surprises then that in the years to come, this patient has poor scar outcomes, difficulty moving that shoulder, and issues with regards to function. And so if we go back the several years between this original burn and this photograph here, it tells us that really early surgery should have been offered much earlier, much quicker, such that we could have avoided some of these complications. The burn size will also drive the surgical decision. The burn size, of course, in this particular case being an enormous burn injury. This is obviously a life-threatening injury, and really this is an unsurvivable injury if you don't operate promptly. So the size of the burn will also drive that decision-making as well. The depth of the burn, clearly this is a very deep injury. The location of the burn injury, we want to minimize morbidity from leaving unstable burn with poor scarring over joints, over precious parts of the body. And the patient will drive it as well. This is someone who's been knocked off a bicycle. They've got significant polytrauma, but these burns are not to be ignored. And so we have to remember that not only do we look after patients with acute burn injuries in isolation, but these are patients with other pathologies, chest injuries and so forth. Those patients still need the burn injury treating, because when the pneumothorax is settled down, when the femoral fracture is healed, these patients still have scars if we don't manage them appropriately. So we have to be thinking very proactively in terms of managing patients with these burn injuries, even when there are other injuries at stake. But of course, environment is important. It does depend on where you're operating. I operate in a very wealthy country such as Australia. I also operate in a very impoverished country such as Tanzania. The two are not necessarily the same, but I think the principles of managing an acute burn injury that is deep with surgical debridement and appropriate reconstruction really spans any border or any continent. So that experience comes from working in burn centres, working as part of a multidisciplinary team, having specific and specialist outpatient clinics, MDTs, professional associations, and of course spreading the word, doing what we're doing now, which is meeting, discussing ways in which to do things, and making sure that we're always questioning and making sure that we get the very best results for the best outcomes possible. Because we want to be able to manage people proactively and get good outcomes. This is a case that I treated some years ago, a 40-year-old lady, a woodworking teacher, who fell in a fire celebrating her 40th birthday. The vulnerability in her case was alcohol and marijuana on board. This is a deep injury. This is not an injury that you sit and watch declare itself. This is an injury that you know is going to benefit from surgery in order to minimize contracture and scar risk. And so this patient was taken to theatre after she's had this silver dressing on. So this is her 3 days post-flame burn. Off to theatre, appropriate tangential excision of the deeper areas and reconstruction with a split thickness skin graft, resell to the areas that were more partial in their thickness. And you can see there she is, 10 days post-injury, 6 days post-surgery, and we've already got a significant amount of wound healing going on. Out of hospital really very, very quickly, and that's her scar outcome at a month's time. So it's being proactive, making sure that we get early wound closure, early mobilization, and this woman's back to work teaching in the school. So how do you get people to have operations like that? How does that system work such that you get successes? Well, I think it comes down to, as you've heard, exceptional patient care, but you get that because patients are well prepared for the operation. And part of that is education. And so we spend a significant amount of money in Western Australia teaching people, teaching in schools, teaching in general practitioners, rural and remote hospitals, ambulance service and so forth. And we teach them, first and foremost, don't get burnt, but if you do get burnt, please apply 20 minutes of cool running water first aid. And if any of you learn nothing else other than simple first aid for burns, then I've done partly a reasonable job, because first aid for burns is so important and it has such a massive impact in terms of minimizing the amount of surgery that we need to do if patients do get really good first aid. So first aid, ideally the minute after you get burnt, but worst case scenario is still useful in terms of reducing the progression of that burn up to 3 hours following the burn injury. And that's research that's been very proudly done here in Australia, principally over in Brisbane. And that's a message that everyone listening to this webinar should take home. Tell your husbands, tell your wives, tell your children, tell mum and dad. If every single human being on this planet knew how to apply first aid for burns, we would drastically improve the morbidity and the mortality from burn injuries by people just simply doing better first aid. Following first aid, really, really important is minimization of infection. And across Western Australia, we use nanocrystalline silver on all our burns to minimize colonization of the burn. We don't want to get into a situation where patients get burn wound infection and then we can't operate. So everyone goes into Acute. We manage their edema very, very actively. As I've mentioned, we use technology to optimize the timing of their attendance if they need an operation to minimize that length of time in hospital for a short hospital stay and early mobilization. People need to get out of hospital and again, keep themselves safe. So it's a real commitment to quality, to making sure that people are interested in doing this surgery, getting the best possible outcomes for our patients. And actually, whilst it may sound very, very expensive, the value for money here is that we're not having long hospital stays. We're not having lots of money spent on very expensive antibiotics because we're not allowing these patients to develop burn wound sepsis because of the use of Acute, for example. And I think it's being flexible. It's allowing your service to expand and contract depending on your need. And I think COVID-19 has very much shown us that during the pandemic, we very much reduced our operating because there were fewer patients getting burnt. Now that Australia has come out the other side and our social distancing is being relaxed, people are partying harder. They are throwing more and more petrol onto fires, and unfortunately, we have never been busier. So a word of warning for those of you that are perhaps still in an element of lockdown, when that eases, you will potentially see what we've seen, which is increasing numbers of acute burn injuries that require surgery. So a little bit of experience with regards to our unit here in Western Australia. As you can imagine, as you can see from the top left-hand corner, the majority of our injuries are in men, so 65% in men. These are, of course, young men. They often do very silly things with petrol. As you've heard, they sometimes throw petrol on fires. They sometimes throw petrols on barbecues and bonfires and so forth, and they sometimes do very silly things like this. So lots of flame burns in young men, a significant number of contact burns, as well as scald injuries as well. And as you can see from this slide here, one of the things that we really try and do quickly here in Western Australia, particularly in the adults, is getting patients to theatre quickly. And you can see from the slide here that the time from actually first surgery, well, from admission to first surgery is pretty short. And really in terms of the average time from the burn to when we're actually operating is short as well. So if you've got a burn, it needs an operation. There is no point in sitting around and waiting. Get on and do that operation. And the figures speak for themselves here. We really get on and do our operations pretty quickly. And the operations that we do acutely, this is just a bit of a snapshot from the past 5 years here at Fiona Stanley. The number one operation, no surprises, would be debridement, skin graft and RECELL. As you can see, a few lasers that are creeping in early, and the images on the right there, just all the other bits and pieces of operations that we do, obviously much smaller numbers compared to the acute debridements and skin grafts. So just as an example of a patient that I treated very recently, I think when you're preparing these presentations, it's good to be front of mind in terms of some of the patients that you treat. And this is a good example of someone who has been treated originally, as you can see, from Katanning, which is about 300 kilometres southeast of Perth. He's sustained a relatively small burn injury, well educated, so good first aid, attends the local hospital, and he's had good dressings applied by the nurses in the local hospital. A referral is at that stage made to our burn service for advice. Photographs are sent, and the patient is told to keep the limb elevated and to reattend to that emergency department a few days later, where the photographs are taken and then sent on to myself in this case, or one of our nurse specialists. And at that stage, we can then determine that, yes, this is a deep injury. We think in this particular case, this patient would benefit from surgery. We'll get them up to Perth, as you can see here. They attended the clinic the following day and were scheduled for surgery the day after that. And we can do that because we have access to theatre. This is our working week in the adult burn service, and you'll see that every day we're able to look at, assess, admit if necessary, new patients. We are always operating every single morning on acute burns. We have consultant presence throughout the unit every single day, not only in theatre but in clinic as well. And we run regular MDT meetings and teaching sessions and so forth. So we are able to do this because of people who are interested and who are expert in doing this. So in theatre, we utilise the same team throughout our burns service within theatre. So there's a degree of familiarity. There's use of local anaesthetics in donor sites. There's use of standard preps. So we can be fairly quick with regards to managing these patients. And as you can see, these are just some photographs that I took of our registrars taking the skin graft initially for this gentleman who's going to require a skin graft, as well as some RECELL We're going to use some of that skin for the autologous cell suspension. And then you can see what I'm doing here is top left, debriding the deeper part of that burn that you saw earlier using this power dermatome. And then probably our favorite friend in the operating theatre is this diamond burr, which really allows us to be very, very sensitive with regards to our debridement. So we can really sort of blend the edges from the area that's going to require a skin graft through to the area that we're going to treat with the RECELL, through to the periphery of the burn. And this really does allow for a very smooth wound, which gives us a fighting chance of getting a smooth skin graft afterwards. So that's the area that's been debrided. We're now going to apply our mesh skin graft. That's a 1 to 1.5 mesh with a little bit of glue around the edges. And you can see deliberately not taken out all the way to the edge, because otherwise we're going to end up with overgrafting. The whole thing will be sprayed with the RECELL autologous skin suspension and then dressed up with dressings applied, as you can see, in a fairly standard manner. For our patients who are being admitted to the ward for larger injuries, for example, we'll be doing our first takedown at 2 days. This patient, who would then be potentially sent to friends, relatives, or hotel accommodation in Perth for 4 or 5 days, and then seen in the clinic for the first takedown. As you can see here, this is him at 5 days post-op, and then at 10 days, that central area of skin graft looking well taken and pink, and the other areas are in the periphery, still on their way to healing, but with a good potential for good outcome. So he's relatively recently since his surgery. But the same would apply for this patient who I treated some years ago. The decision is made there on the 18th of July. This is a patient that needs an operation. There is no value in waiting to see how much of this is going to heal around the edges. What we want for this particular child is an early operation. From recollection, this patient had the operation the following day on the 19th, and you can see on the 25th of July there, a well-taken skin graft. And as you can see, the long-term outcome for that is a graft that is looking good, will grow with that child, and will hopefully mean that, you know, very, very little further surgery will be required over the course of that patient's life. What about bigger injuries, the patients that require resuscitation? Well, meticulous fluid resuscitation, of course, nasogastric feeding, lots of prehab. We have physios coming out of the woodwork everywhere in Western Australia. And so they really provide a huge benefit for our patients pre-operatively and post-operatively. Single surgery, again, whatever's necessary, skin graft, RECELL, utilizing those same techniques as we would have used in that smaller injury. And again, generally speaking, good outcomes, and the patients are happy with how things have gone. With regards to the massive burn injuries, immediate scrubs, escharotomies, and so forth, utilization of ICU, of course, and then excision on our standard burns lists, or in the case of weekends, we will summon the staff and run extra lists if we need to do those operations after hours or over the weekend. And we will aim for total burn excision, utilizing, again, the whole spectrum of techniques. Reconstruction, really with, as you've seen, RECELL and BioBrain, RECELL and SurfaceSoft, as you've seen, skin graft, RECELL, and of course, dermal matrices as well. There are some patients where we will hold with VAC or negative pressure and then proceed with surgery when a lot of that edema has settled down following the resuscitation period. So able to get significant good outcomes despite some really very disabling injuries, even in some of these massive injuries. Just another case that we treated recently before I finish, a gentleman involved in a meth, well, I would say a meth lab, but it was like a meth van injury. For some time, we had quite a lot of meth labs. In fact, when I was the fellow here in Perth, we had so many that we were able to write a paper on it with regards to our experience. But the meth labs certainly produce very, very complex burn injuries in what are very often complex patients with pre-existing drug and alcohol dependence. And you can see from our records here, quite a significant burn injury. But again, the same is true. We want early excision of this burn if he's going to survive this injury. So at day 0, scrub and escharotomies, Acute to all the burns, counterstat along those sclerotomies, full ICU support, such that we can then crack on and do a full excision on day 2. This is done with 2 consultants at the very least. It's all about getting on, doing as much as we possibly can. And as I've mentioned, a combination of techniques. If we don't need to go hard and take the burn off in its entirety, we will dermabrade and hold with ReCell and BioBrain, particularly for areas such as the back, which means that we're not having to harvest vast amounts of skin that sometimes we don't have. For some of those deeper injuries, we will use monopolar and do a fascial excision. So it's about the technique being appropriate for that particular burn. So this is him weaning himself off ICU, everything healing up pretty nicely, and really aiming for early mobilization out of ICU onto the ward, such that we can get these people going as quickly as we can. 28 days post-injury, he has a Versajet wound prep and skin grafting to the 2nd stage of his BTM, his dermal matrix, and some further skin grafting, such that his journey through the hospital and through our service can be as prompt and as quick as possible. And you can see this is his sort of date line with regards to his admission, his surgery, and his discharge, and really a very pleasing outcome with regards to be able to get him out of hospital, certainly under his, you know, I guess proposed 65 days in hospital. He was out, as you can say, certainly shy of that. So what is the take-home message? Well, I really think, as I said, if you learn nothing else or want to do nothing other than what I say today with regards to surgery, it's the first aid. If we can encourage other healthcare providers and our patients to deliver really good first aid, we have shown that our patients require 50% less surgery. That is astounding in terms of such a simple thing such as first aid being able to change what we can do surgically. And 50% less surgery means 50% less skin grafting, 50% less ReCell, 50% less deep injury, which therefore makes this earlier surgery even easier or more applicable. I think people need to be really meticulous with their fluid resuscitation, their nutrition, their edema control and their physio, particularly for the larger injuries, such that our patients are really optimized, such that we can hit the ground running and get on and do these operations really within 48 to 72 hours following their injury. Early surgical debridement, clearly dependent on the depth of that burn injury, on the size of the injury and where that injury is, really can be very sensitized towards that particular patient and that injury. And early reconstruction with like-for-like reconstruction, early mobilization and discharge. As you can see in this photograph here, a deep injury in the center of that wound that we can treat with a skin graft and really aim for, you know, a very good outcome with regards to his function. So specialist areas, head and neck, high voltage injury. Alex will remember this case because she and I did this some years ago. This is something that is obviously life and death. And this is where you really do need to utilize all your tools in the reconstructive toolbox. So burnt from 30,000 volts to the head, also an exit injury to the arm. And this requires the full remit of plastic surgery. In this case, we did a free latissimus dorsi with a widely meshed split thickness skin graft over the top. And as you can see, these contract down beautifully. Scar outcomes are good, and we've not needed to do any tissue expansion or anything. So utilize the full remit of your reconstructive abilities in dealing with some of these complex injuries. He had an exit wound on his arm as well, which we utilized a perforated flap for, this little posterior interosseous perforated propeller flap to cover his EPL. And again, a good scar outcome and a good functional outcome for him afterwards as well. For the low voltage electrical burns, whilst I've been talking about early surgery, these ones I'm happy to wait a little bit longer, perhaps a week or so before operating. Otherwise, you find that you debride, you put your skin graft on, and the whole thing falls off because you've under debrided. So these ones I would wait a little bit longer. This is a standard split thickness skin graft, but has done very well because of our abilities to actually debride appropriately and get good graft take first time round. And just the use of a a dermal matrix, in this case matroderm, to cover a much smaller area of exposed EPL following a crush and a thermal injury at the same time. Another free flap, again, like-for-like reconstruction. This chap's missing skin, he's missing fat. I'm a great fan of using perforated flaps and fasciocutaneous flaps across my reconstruction, and burns being no different from any other defect. So like-for-like reconstruction in this situation would be, in my hands, a fasciocutaneous flap. So we used a little skip flap in this patient. And again, in terms of long-term outcomes, abilities to get back on the motorbike, to walk, to run, to have a normal existence without a horrible scar on the foot, that is the best outcome that we can do for him. So, final slides. As you will have heard, I'm a great believer that early surgical interventions are not only life and limb saving, but also have huge economic benefits and huge benefits in terms of the point of view for the patient. I really want people to think innovatively in terms of their excisional techniques, but also to use all those tools that we have in our toolbox as plastic surgeons to reconstruct those defects most appropriately. These are my final T's. Talk to the patient, talk to your colleagues. Timing is also really, really important. Keep your patients warm, because if they get cold, you can't do the surgery. Think about those techniques and really individualize that. It makes it far more interesting as surgeons if every patient has got a very individualized treatment technique that's being given. Don't forget about infection control, because it's really, really important still. And work as teams. You can't do this on your own. I'm really, really privileged to work in a great team here in Western Australia that allows us to get these great outcomes, but you can't do it alone. So have good friends and keep them friendly. Thanks very much.
Great. Thank you so much, Jeremy. That was a fantastic talk and a really nice broad overview of the work that you've done over the years in Australia, but also abroad. There are quite a few questions coming through, but if you don't mind if I just kick off with a question about RECELL. Yeah. So clearly you're in the birthplace of RECELL and you use it quite regularly, even on smaller burns. Do you find that it even benefits even those smaller burns, and there is really a good use for it given the cost for small burns where you're grafting anyway?
Yeah, I think there is. I think that some of the examples that you saw there really do allow us to be a lot more sensitive with regards to the skin grafts that we're using. I think if you don't use RECELL in some of these cases, you're either just going to not do an operation, and then you run the risk of leaving those patients to have no operation, and then the risk of a poor scar because you're not going to get them healed quickly because you've not given them an operation. Or you end up overdoing it, and so you end up skin grafting stuff that then looks overgrafted and again contributes to poor scar outcomes. So generally speaking, if I've got a burn that is of variable depth, so the example of the gentleman from Katanning, where you've got that central area of a much deeper injury that requires a skin graft, and the periphery, which potentially will heal, but will not heal as well if we don't add in that RECELL. I think the RECELL does help. And going back to the photograph of the lady who'd fallen in the fire, I think she's got a good scar outcome because her scar is blended. And what patients dislike, I think, when you skin graft them is they don't like that line between where their skin graft is and where their unburnt skin is. And if you can blend that by whichever means possible, and I think a good way of doing that is with dermabrasion and RECELL, then that's a real winner. And I think our patient scar outcomes and our patients' appreciation of what we've done for them is better, even in those smaller injuries.
Thanks. And along those lines, there's a question from Cape Town, South Africa, from Ernst Muller, who says, fantastic talk, and wondering what dressing or contact layer you would use over the RECELL and thickness skin graft, and when you would do the first wound check.
Yeah, so we generally use a product called Surfasoft over our RECELL here in Western Australia, and most of those are checked at about 2 days, but you can, some of them would be left 5 days. It really depends, as I said, on whether you've got an ambulant patient that's going to leave and then come back for a first dressing in the clinic at 5 days, or whether we're going to be a bit more proactive if they're an inpatient and then look at them at 2 days. So we'd use Surface Soft. You can use Telfer. Telfer is a very good dressing to put over the top of RECELL, but probably one of the best dressings, providing you've got it available, is Barbrain. That's a really, really good dressing over the top of particularly a purely RECELLed patient.
And I noticed in your data that the smaller burns have a longer time to surgery. Do you know why that is? Is it because people are not sure whether they want to have an operation?
No, I think it's actually deliberate, very deliberate. It's about someone having a burn on a Friday night. There is little point in them coming to the burns ward on a Saturday morning. We will make sure that within the advice that our registrars are giving those patients in EDs at Friday night to do the first aid, to put the Acute on, they come to our clinic on Monday morning, at which point it's an easy decision. Right, you need an operation. You'll then go on the list on Tuesday or Wednesday. So that's why those smaller burn injuries are perhaps 4 days, still pretty early, not 14 days or 20 days, whatever. So they're getting their operation at about 4 days or whatever. Whereas if you come in with your 80% burn, we will operate on you that night. We'll do your ascorotomies and so forth, and then they'll get on and have their operation. So the inpatients often do get their burn treated surgically a little bit quicker because of that.
Makes sense. There's another question about enzymatic wound debridement, things like Nexibrid, and whether you use them in your fields.
So I have a little bit of experience in using Nexibrid. Nexibrid has not yet got TGA approval, so we're not allowed to use it, technically speaking, here in Australia. It's certainly something that looks very, very promising, and some of the stuff that's coming through from Nexibrid in particular is looking at time to decision making, time to operation, and some of the data that I've been seeing on Nexibrid looks like that decision making, if the patient needs a debridement, that decision can be done, and surgery or the debridement with an Nexibrid is done within a day. And that's actually not too dissimilar to some of the things that we're doing with our debridements as well. So I think Nexibrid's really exciting. It's presumably the way forward, and I think it's actually going to mirror some of the stuff that we're already doing in terms of early debridement.
There's a question, actually, because this is an international seminar, we've got questions from all around the world, and places where presentations are often different. And there's a question from Indonesia asking about when they often see delayed cases. So patients arrive often over 8 hours post-trauma or maybe beyond, and how you manage their fluid resuscitation when they're quite a long period out of their original injury. Sorry, did you miss that?
I did, yeah. I don't know whether it was my signal or someone else's signal. Can you just repeat the question?
So it's a question from Indonesia where they see delayed burns. So patients who come in with their acute burn often over 8 hours post the original injury or beyond, and how you manage their fluid resuscitation.
Okay, so I mean, if you're out and beyond 8 hours, I think fluid resuscitation, we have to remember, is really a starting point. It's a gauge and it's a guide in terms of maintaining some element of normal tissue perfusion. And so if you're beyond the 8 hours, even if you're beyond the 12 hours, 16 hours, whatever, it's about trying to normalize that patient in terms of blood pressure, pulse, urine output, and really titrating to urine output from that first opportunity that you're there. So I'm really against flooding people with the first 8 hours worth if there's no benefit in doing that. If you start them off on, I guess, a Parkland appropriate for catch up, and really most importantly monitor that urine output hour by hour. And a lot of those patients, you can massively jump down on the resuscitation because they may have been eating and drinking anyway. But it's a commitment to actually monitoring the urine output. And that's one of the things that a lot of people just don't do very well. They sort of feel that they can just set the Parkland formula running and it'll sort of look after itself for the next day. And that's just it's so wrong, and that's how we end up with people who are either horribly over resuscitated or in sometimes under resuscitated as well.
Thank you. There are so many questions. I'm just going to pick out one more, if that's okay, before we move on. And it's about BTM, and this is from Lewis Stingle in the UK. He's asking about your use of it, because you seem to be pioneering it in Australia, and in the UK, we don't have approval for it yet, although it's coming. What's your general experience of using it in burn surgery reconstruction?
So yes, so another British burn surgeon here in Australia has developed that. So John Greenwood in Adelaide and Marcus Wagstaff, a contemporary of mine who is also in Adelaide. They've been really working very, very hard with BTM. Yes, we have it available here in Australia. We have used a fair amount of it here in Perth in acute burns reconstruction. I've used a bit of it in other plastic surgery reconstruction as well. The take-home message in this at this early stage, and of course, you know, we have to be careful that we're not sort of over jumping the gun a little bit in terms of, you know, declaring great success for this, is that so early days, good take, probably a little less prone to infection compared to Integra, and as far as we can see, reasonably easy to look after in terms of nursing, in terms of second operations for skin grafts and so forth. So early days, but yeah, very, very, very encouraging that we're not seeing as much of it sort of being, you know, washed down the drain with infection.
It sounds really exciting. Okay, so
yeah,
in the interest of time, I think we'll move on to our next fantastic speaker. So this is Alexandra Murray, our burns lead here at Stoke Mandeville, who's going to talk about burn scar reconstruction. So thanks very much, Jeremy.
Thanks, Jeremy, for your great talk. A tough act to follow. Okay, so thanks very much, everybody. And I hope that I can cover sort of the key areas this morning or this afternoon in Australia on scar reconstruction. Just a little bit of background to my journey into burns. I trained in London and Yorkshire in the UK. You can see up here on the left is Pinderfield's Burns Centre in Wakefield in Yorkshire. And there I was inspired by Alan Phipps and Orla Austin, and also Jeremy when he came back from his Burns Fellowship in Perth. And we had a great time working there together, learning the nuances of acute and delayed burns reconstruction. I was then fortunate enough to have fellowships in Australia, both in Melbourne, learning microsurgery in more detail with Damien Grinsell, and also working at the Alfred with Heather Cleland in the Adult Burns Centre there. But it wasn't really until I got to Perth for my more consolidating fellowship that I really sort of became very much focused on all the small minutiae of details, a bit as Jeremy has alluded to about how you lay the graft to ensure that the scar outcome is as good as it possibly can be. And we also set up a laser service whilst I was working there. And you can see in the middle photograph at the bottom, Fiona Wood and Suzanne Ray, and also Jeremy, my great mentors there. Coming back from Australia, my first consultant job as a locum was at Nottingham, working with Graham Perks, Kieran O'Boyle and Tony Fletcher. And this is a very busy adult and children's burns service with a fantastic team. And definitely the thing that sticks with you is the great teamwork that occurs throughout all the burns services in the world, I suspect, but certainly the ones that I've had the privilege to work in. And now at Stoke Mandeville Hospital as the clinical lead for burns, we've done some great things over the last few years together. So good burns care really matters. It matters because there are 11 million burn injuries per year across the globe. It matters because 70% of these patients have significant lifelong scars. And also, you know, the death rate is not insignificant, 180,000 per year across the globe. And as Jeremy's spoken about already, unfortunately, some of the most severe burn injuries continue to occur in low and middle income countries. There is therefore a huge discrepancy still, even now in 2020, in survival from burns and also in quality of life outcomes because of the resource that's required to deliver a world-class service, as Jeremy's been talking about in Perth. This takes a lot of money and a lot of resource and a lot of manpower in order to achieve these fantastic outcomes. So really there's still a huge scope for change in burns, which is one of the other reasons that it really matters to be part of it. And indeed to minimise the cost to the patient and the cost to you know, the healthcare services across the world. And why burns care matters as a career. So for those of you that are budding plastic surgeons or from other surgical specialties, burns care allows you to make a difference at home and abroad, and you have the opportunity to save lives. Not to sound heroic, but within plastic surgery, it's one of the few areas which you can perform life-saving surgery, and therefore gives you a much greater understanding of the critical care aspect to the patient and provide a holistic approach. I think burns care also gives you the opportunity to work in amazing teams, and if you're interested in leading that team, then this is a great speciality choice. The other thing which I really enjoy is the opportunity to look after adults and children of all ages, from all walks of life, of different ethnicities, and really to understand the complexity of society and look after the most vulnerable. And we can see patients all the way through, particularly the children, from the start of their journey into adulthood, which can be extremely rewarding. Occasionally, there is the odd patient that might challenge you more, but there's always a team to help. Of course, we can engage in high quality burns research and be part of what is essentially quite a small international burns community. There's only approximately 70 burns consultants in the UK, and there's a small number of burns specialists across the whole world. So really you get to know people well when you go to meetings, and we all support each other with challenging cases. So I come back to this quote very often in my talks, which belongs to Fiona Wood, which is that every intervention from the time of injury affects the scar that is worn for life. And really, we have to start at the very beginning with what are the risk factors for burn scarring. And we know that patients that are burnt have between a 30 and 70% risk, quoted in the literature, for developing post-burn scar. Young patients, so children, have got a hyper-reactive immune system and are more prone to forming aggressive scars, as are females. And this is unfortunately more related to the global use of kerosene cooking stoves, and therefore flame burns in females across the globe are more common. Skin type, of course, increases the risk of scarring with a higher Fitzpatrick score. Flame and chemical injuries, and obviously the deeper and more severe injuries, will definitely cause more scarring. Time to healing is extremely crucial. And we also, in the literature, meshed skin graft, although you can see from some of Jeremy's fantastic pictures that if a meshed thin skin graft is used well in combination with cells, then actually we can reduce donor site morbidity and improve scar outcomes. We've already talked about first aid, and with any scar, prevention is better than cure. So let's not forget that first aid has a huge impact and the health and safety associated with hot water temperatures in the home, etc. This paper published in 2016 showed that water first aid reduced the need for skin grafting by 13% and reduced length of stay by 18%, which is, of course, has a huge impact on the patient outcome. More recently, from our group in Stoke Mandeville, the Restore Research Group, there's a paper that has been published that actually demonstrates the scientific effect of cooling in order that the hair follicle gene transcription is preserved, and therefore the ability to produce keratinocytes is actually preserved through proper cooling. Now, this is just a summary of the key things that there is solid evidence of sort of level 2 and above, of things that will reduce and prevent scars. So in other words, if patients have got access to specialist MDT care, if they have really, really good meticulous resuscitation to preserve as much of that deep dermis as possible, early surgery, really getting that burn off quickly, getting patients healed quickly for sure is extremely important in the long-term scar outcome. Dermal preservation techniques, so there is some good evidence. These are level 1 papers for using Nexabrid enzymatic debridement, for using Versajet and dermabrasion, which are much more meticulous ways of debriding the acute injuries and ensuring that the long-term scar outcome is as good as it possibly can be. Dermal templates and substitutes, we've heard a bit about BTM. The other commonly used ones are Integra and Matroderm and Pelnac. And so far, these are definitely coming further and further into the forefront, both in acute and delayed reconstruction for burns. Cell-based therapy, so we're really talking about 2 types of cell-based therapy, ReCell and cultured epithelial autograft. And the idea of these is to act as an adjunct to expedite healing, to reduce scarring as a result of that. Early healing, we used to talk about the 21-day rule. We've sort of moved forward from that, and this Liz Chip paper from 2017 clearly demonstrates that for every 1.14 additional day, we have an exponential increase in the likelihood of poor scarring. So really, prevention and all of these early strategies are the key things to reducing the need for complex scar reconstruction in the future. But nevertheless, we still have our scar management strategies in place. So let's start with the burns MDT. Essentially, we work together with the psychologists, with the occupational therapists and the physios, and we go through the patient priorities. And a bit similar to in the acute situation, in the delayed situation, we really want to have an individualized management plan that is very much tailored to the individual patient and what they need. And we really need to focus on best interests. It's not about us choosing to do the most exciting operation. And we need to particularly think about this in children because we have to sometimes be their advocate as much as possible and work closely with their parents. So these are the key considerations. In children, we need to think about growth. So if there are scars that are crossing joints that might limit growth, then these need to be addressed fairly urgently. We need to think about key functional areas, and we'll come on to some of these shortly. We need to think about cosmesis, and sometimes for us as reconstructive surgeons, our key concern is function, but the patient's key concern might actually be cosmesis. So you may need to start with a combined approach addressing 2 things together. Really, really important that the patient is psychologically optimized as much as possible before embarking on any complex reconstruction, because they need to be able to tolerate it. They need to be able to have the resilience to get through these operations. And so it is up to us as an MDT to ensure that patients have these operations at the right time and are psychologically prepared to undergo them. So it's very much a holistic approach. Some of the key things for scar reduction, which I'm sure most of you are aware of, the use of pressure garments to reduce height, and recently the Pegasus study from Birmingham, which was essentially testing the water to see if pressure garment use could be looked at in a randomized controlled trial, has demonstrated how challenging it is to really do randomized controlled trials in looking at burn scars, but certainly they have a huge part to play in our patients' recovery. Silicone. The theory behind silicone is that it improves oxygenation and also potentially moisture within the scar, and we're hoping to launch an RCT at Stoke Mandeville looking at silicone in a more specific scientific way in an RCT model. Exercise therapy. So with fantastic physio support, our patients can really maintain lean muscle mass and can achieve the maximum stretch on these scars that are battling and wanting to contract. So exercise therapy is really, really important right from word go. Massage. Massage improves pain and itch and is certainly a standard part of our scar reduction modalities. Moving on to other things, and Helen's going to talk in more detail about laser, so I won't go into this, but certainly there's some really good growing body of evidence to support these additional adjuncts, which are low risk, thankfully low downtime strategies that patients really like, and are a good way of putting in early interventions for hypertrophic scars in the first few months to ensure that the long-term outcome is as good as it can be. So this is a picture of the CO2 laser being used, and really the aim is to convert an aggressive hypertrophic scar into a more mature, soft, remodeled scar as soon as possible, and therefore that patient can potentially come off gabapentin, can potentially come out of pressure garments, and may even reduce their requirement for more complex reconstructive surgery, which at the end of the day is great for them. It might mean that our operating waiting lists are not as exciting in the long run, but much better for the patient. These are other examples of hypertrophic or unsatisfactory scars. So the one on the left might be suitable for an early steroid injection just to flatten that out. This is a thin, aggressive hypertrophic scar. And then if that scar responds well to steroids, that might be sufficient. Or if not, then you might consider things such as excisional surgery to reduce the scar completely. Whereas this broad hypertrophic scar on the right-hand side of the neck responds well to different laser treatments, including pulse dye, as it's quite erythematous. So with the reconstructive journey, what I would recommend, and what was recommended to me when I was training, particularly by Suzanne Ray, who's a great mentor to me on fellowships, is to start small. Start with something that's low risk and low downtime, because this allows the patient to trust you and for you to build up a rapport with the patient. Burns patients have been through a lot. They're often vulnerable, psychologically traumatized, and will often actually be seeking out something that gives them small steps forward, as opposed to having a huge inpatient stay or a long recovery time. So starting with some of these low risk strategies such as steroids, laser, microneedling, etc., is a good way to begin your reconstructive journey together. And following on from this, you can then assess that patient and obviously the parent, if it's a child, resilience and compliance for treatment. At the end of the day, you don't want to embark on a major reconstruction if that patient never turns up for any appointments afterwards, or just really can't cope with it because of the psychological trauma that's gone before. If you have a positive response to this test procedure, then I would recommend that you then move to those procedures that are really required to address the key functional issues. At the end of the day, these are going to be higher risk and high downtime, but don't forget that you can always wait if needs be, as this is not a malignancy, and it's better to do this at the right time for the patient and the right time for you. So this is where we come on to Gillies principles. And one of the beauties of scar reconstruction is that it really takes you through the full remit of plastic surgical tools. Make sure you have a plan. Do not throw away a living thing. So therefore, if you're operating in scar tissue, if there is reasonable quality, mature scar tissue, you need to be absolutely certain that what you replace it with is better than not what was there before. Thou shalt treat the primary defect before worrying about the second. So for someone with a very, very broad neck contracture, you really need to think about addressing the entirety of that contracture as opposed to picking the operation that you think will be most exciting. And obviously, in all parts of plastic surgery, you should have a lifeboat. And as I mentioned before, timing. So thou shalt not do today what you can put off until tomorrow. So that's relevant, not so much for acute burns care, as Jeremy has mentioned. Early surgery is very, very important. But planned early surgery is crucial. And in the same with reconstruction, if the patient is not ready, then it's important that you are patient and wait. So this is just a little bit of an overview of how I sort of think about things and how I was taught to think about things in my training. You really want to think about whether a scar needs an incisional release or an excisional release. And I'll talk a little bit more about that shortly. And really then we have our full plastic surgical toolbox at our feet. So we can use local flaps, we can use split or full thickness skin grafts, we can use dermal templates, tissue expanded flaps, perforated flaps, either local or free, and of course all types of free flaps. And then the most complex of all is allotransplantation. And actually, Fadi can probably tell you more about this on another day. But really, face transplantation has been most commonly used in the treatment of very, very, very severe facial burns. And you can see on the side of this, I've put the adjuncts, so the laser and the steroids and the adipose fat transfer as well, which can be used in combination with these techniques in the same sitting. To avoid patients having multiple general anaesthetics where possible. Now, I've put this in to explain what I think about incisional versus excisional release. So you can't make a silk purse out of a sow's ear. And essentially what I'm referring to is that if you've got a thick, broad area of very unstable or chronically infected scar, that despite your standard adjuncts really is not changing and improving, then this is the kind of scar that is going to have the most benefit from excisional release. I hope that makes sense. And really that allows you to have a good risk benefit ratio. And just going back to Gilly's principles again, it's important not to throw away reasonable quality mature scar, because you are going to create an unnecessarily large defect if you do that. So these are some of the common sites that we end up performing scar releases for: the eyes, the mouth, the neck, the axilla, the elbow, the hand and the wrist, sometimes the groins, which can cause a lot of discomfort if the groins are tight. And then a separate area is scalp alopecia, which really has got a fairly standard approach for reconstruction. So for choice of reconstruction, we want to know what the local skin quality is like. We want to know what the donor site availability is. And we also need to think about what the likely defect size is going to be once we open up this very tight scar. And of course, it needs to boil down to patient preference, with a very much informed choice made together with them. And if it's a child, their families and the MDT. So I'll start with the neck. I'm really just going to focus on sort of three key areas which are most commonly treated. So I've put on the left-hand side of this table here your different reconstructive options for the neck. And I'll just talk through the pros and cons of some of these. So for instance, with a neck contracture in a very unwell patient in the acute early phase of recovery, you might want to do something quick and safe and use a split thickness skin graft. we know that that will recontract for sure, but it might be very, very important to allow, you know, improved function, to allow, for instance, trachecare, or to heal a chronically open area. So that would be, you know, essentially an acute bailout preference, really. Full thickness skin graft and Z-plasties. So you might use these, for instance, with a small extension deficit of the neck, or if there are very specific narrow bands. And I would put these in for use for an incisional release. So where you've got adjacent tissue, which is reasonable quality, and you've also got a mature scar. So if the scar is still very angry and hypertrophic, then I would suggest holding off using these until the scar is more mature. With both of these strategies, there'll be relatively low downtime, and these are a pretty low risk, but they will not address the more significant contracture of the neck. So moving on to the more significant neck contracture, where we've got an area of broad scar and also more significant extension deficit. Essentially, we can choose between these three. Where there are limited donor sites, we might want to start with a dermal substitute with split thickness skin graft, or the other option is to take a thick, is to take a thick split thickness skin graft and then overgraft the donor site. Both of these options are relatively low cost to the patient, but both of these options can recontract. And we know that dermal substitutes can be prone to infection, but certainly a useful option. Tissue expanded flaps. Now, these really provided you've got good supraclavicular skin, these will give you really good like-for-like colour match for the neck. But it requires the patient to be compliant, to be fully informed about the downtime that's required and the multiple visits for tissue expansion. And we'll certainly need 2 to 3 additional visits for inset to ensure that it's all looking as good as it possibly can be, but can give some really fantastic results and good, pliable, thin, robust skin. For free flap options for the neck, this obviously requires those donor sites to be good. They might be scarred, so you might not have that option. But if they're not scarred, then generally an ALT or a parascapular is a good option, particularly if these are relatively thin with a relatively thin fat layer. This has got a better downtime profile than the tissue expansion, although we are limited by the actual width that we can take. So in other words, you don't want to have to graft the donor site on the leg or the back or wherever, leaving a very unsightly scar from where you've taken the donor tissue. So it's important to think about what you can achieve with your flap. If you can't address the whole neck contracture with your free flap, then that's probably not the best choice. I hope that makes sense. So this is a little girl who was involved in a bomb blast in Syria. You can see that her contracture actually involves the area around the mouth and the upper neck as well. And this is a difficult case. You know, you could talk about using dermal substitute and skin graft. You could talk about free flap options. Now, I decided after she had lots of laser therapy and steroids and discussions with the MDT and colleagues that we would use some tissue expanded flaps from the supraclavicular area for her. And although she's still not regained the chin contour, she's got some good, pliable, healthy skin there, which will grow with her. Certainly, we wouldn't have achieved that width of tissue from any free flap donor site. And she certainly will need secondary revisional procedures to add in a greater length into that scar. Now, just to think about a different type of neck contracture, you can see there's some very specific bands here. These could be addressed with some Z-plasties because we've got good quality tissue centrally, But of course, there's a broad contracture going all the way around beyond the midlateral line that will need an incisional release and reconstruction. So for this patient, we don't have the option of good supraclavicular skin, and we don't have the option of a parascapular flap because the back is also scarred. So really, it's important to think about all the options and tailor your approach to the specific patient needs. She's coming up on the theatre list, and she will probably have dermal matrix on either side of this scar. The axilla. So I'll whiz through these. We've talked about split thickness skin graft only for the acute phase. Full thickness graft and Z-plasties, again, is useful for the specific bands or where there's a small functional deficit. Dermal substitute, again, is really useful around the shoulder and the axilla and is low cost to the patient, but it will, to some degree, recontract. The TDAP flap, the thoracodorsal artery perforator flap, is a good option, particularly where there are good quality adjacent skin and perforators that you can listen to with the Doppler. This gives like for like. It's a lower downtime than dermal substitute, although it is again limited by its width. So it may require additional procedures for inset too. And again, the free flap options are there. So this is a teenage boy who, again, was a victim of a bomb blast. His entire shoulder has been contracted since early childhood, with the joint involved as well. So we started with the posterior shoulder, which was the tightest area. And here you can see integra and skin graft inset there. Now he's got quite a good TDAP donor site here. So most likely his next procedure will to be address the anterior axilla and come into this tight area here at the front. This is an example of a TDAP flap actually that Jeremy and I did together a while ago in Perth, used for an axillary contracture. You can see it sitting nicely there, but it's a bit bulky, so we'll need some thinning down. And also the maximum point of its inset has got some early breakdown. Hopefully he's doing well now. And again, just to give some more examples of axillary contractures. So this is affecting the anterior axilla, and this is a broad area which will need a wide incisional release. So, you know, just think about the scar, think about where it sits and what the best option is going to be for that patient. Just moving on to the hand now. Okay, so really in the hand, we're not thinking about split thickness graft for reconstruction at all. Full thickness skin grafts and using local flaps such as Zeds, Jumping Man, etc. For these flexion deficits and for the tight first web space. And these reconstructive options are used for incisional releases and thankfully a low downtime and relatively low risk, and are extremely useful for burn scar hand contractures. If you have a broad unstable scar on the back of the hand, then a dermal substitute works really nicely with a split thickness skin graft over the top, and this comes into the category of an excisional release. And because it's off the shelf, it's low cost to the patient, although it may recontract. For the hand, in terms of flaps, really there's some good options for pedicled flaps if the donor sites are good. So we've used the groin, the posterior interosseous, and the reverse radial forearm. And all of these options are really good options for the hand. The groin flap is very thin and can be tailored to different defects. Obviously, the posterior interosseous is limited by its width, and the reverse radial forearm has got an even more significant donor site if you need a large area. So it's important to factor this in. In terms of free flaps for the hand, I think groin, ALT, and parascapular are probably the ones that are most commonly used. And these have got a slightly better downtime profile than using substitutes or a pedicled groin flap, for instance. but again, we're slightly limited by the width and the shape. And don't forget for the hand that you might need joint releases and often K-wires to maintain the fingers in the better position once they've been released. So involve your hand surgery colleagues and discuss these cases as a team. It's really important to have a team approach. So this is an example of a little jumping man flap using the dorsal skin from the web space, and then some inset full thickness skin grafts on the side of the digits. This poor lady was a victim of assault with petrol and flame burns to both her upper limbs. This is her right hand prior to reconstructive surgery. And you can see the extent of the flexion contractures of the digits, the tight first web space. She actually had some recurrent infections in the DIP joints. And really, this is a very challenging situation. Her left hand was exactly the same as this, and we started with this hand as it was her preference to start with her left hand. And you can see we've actually used a pedicle groin flap to incise and release all the scarring on the dorsum, and then to inset that into the first web space to give a reasonable function. All the fingers have been released as well with full thickness skin grafts on the volar aspect. The joints have been excised and the fingers have been wired into a partial flexion functional position. And she's now got a much better functional hand as a result of that. And she was prepared to have the hand in the groin for that time, as we talked to her about that would give us the best option to tailor the flap and do 2 or 3 stages to ensure a really good inset for her. Another example of a hand contracture, you can see a very aggressive hypertrophic scar, a tight web space, and the dorsal skin is all involved. This patient had an inset full thickness skin graft here, lots of laser therapy, and so a sort of tailor-made plan to suit the patient and to suit the scar. And just briefly on scalp alopecia, and really the mainstay of management for this is tissue expansion, which can give some fantastic results. And I'm not going to talk too much about the details of tissue expansion now, but it's really important to plan this carefully, use meticulous infection control, see the patients regularly and keep a close eye on them, and make sure that you ensure that the patient is appropriately counselled before embarking on this journey. But it really, really works well. With smaller areas of scalp alopecia, you may be able to manage with a degree of serial excision. So, the future. I think really the future is about standardising our patient-centred outcome measures to ensure that we all know that what we're doing is good for the patient, and we can compare and contrast results across the world for similar techniques. I think there's definitely going to be a move towards modifying genetics and molecular therapeutic targets for scars, which will be really exciting. I think we'll be certainly expanding the use of these dermal preservation techniques such as Nexibrid in the future, which in the long run will improve patient scar outcomes. Laser assisted drug delivery is also something which I'm sure Helen will touch on. And finally, cortical training, which is kind of in the ether at the moment, but whereby we can actually unscar the scar from the inside. So we can teach patients to start using limbs more normally again after the scar, and to reduce the impact that has had on their cortex. So in summary, as a passionate burns reconstructive surgeon, it's really, really important that you take a patient-centred approach. And it's really, really important that you work closely with your team, with your psychologists, with your therapists, and include the patient and the parents of children as part of that team as well. Where appropriate, I think it's really useful to have a test procedure where you gauge the patient's resilience and compliance. And so something simple like laser or steroids or microneedling is a good way of starting your reconstructive journey together. Have a very specific plan for the site that you want to address, and think about all the options available and what options are going to work best for that patient and for that particular scar. Don't forget Gilly's principles, and don't forget to think about becoming a future burn surgeon. Thank you. Any questions?
Thank you very much. Thank you very much, Alex. That was a wonderful, systematic review of all the different types of reconstruction for burn scars. I apologise for the fire alarm, but we're just going to work through and hope that we survive. There are quite a few questions that have come through, actually, some really interesting ones, and some that have been asked by a few people about hyper and hypopigmentation of scars and how you address that very difficult problem.
Yeah, sure. Sorry, I didn't really touch on that, but essentially, I think hypopigmentation, and feel free to interject, Jeremy and Helen, but I think hypopigmentation is very difficult to treat surgically. Certainly, if you've got a nice, flat, smooth area, then camouflage or tattooing can work well. For hyperpigmentation, I think the best approach is either to use, the YAG laser, or to use a dermabrasion technique, a very gentle dermabrasion technique, with or without ReCell, just to allow repigmentation in a more normal way. I don't know if Jeremy and Helen have got any other thoughts on that. No? Okay.
Yeah, I'd agree. I think that the use of laser is good for hyperpigmentation, but you're limited to the skin type of the patient. We've had some success using a CPG handpiece of the laser. I think you got me onto that, Alex, for the mildly dyspigmented scars. But for hypopigmentation, dermabrasion and ReCell to try and put some melanocytes back into the scar is the only thing I've found effective.
Yeah.
Jeremy?
Yeah, absolutely. I think for small areas in particular, if you can resupply some melanocytes with, for example, ReCell, then that can be very, very useful. It's difficult to predict how good your outcomes are going to be, so you have to have very patience, but sometimes it can work very, very well.
The other thing to say is that we obviously tell our patients to keep out of the sun for 2 years and to put lots of high factor sun cream on. But if you've got a very stubborn area of hypopigmentation, then you can cautiously advise that patient to reintroduce themselves to a little bit of sunshine. Not to lie on the beach for 5 hours, but to to have maybe half an hour late morning, half an hour late afternoon, and just to try and re-stimulate, some melanocyte, regrowth.
Great, thank you. So your overview of neck contractures, I think, was really helpful. And I wish I had that just before the FRCS exam, actually. I don't know why you never gave us that presentation. There's a question about the use of prefabricated flaps for neck contractures and what your thoughts are on those. Yeah,
sure. I mean, I think my only experience of that is using a tissue expanded flap. So I think obviously that is a big journey for the patient to embark on. But I think if you feel that if for instance, if you've got a very, very broad neck contracture with a significant extension deficit, and you feel that that's going to give them absolutely the best reconstruction, then there's no reason why you couldn't go for, say, a pre-expanded ALT or pre-expanded parascapular in particular, provided that is a good donor site, as in it's not been burnt already.
There's a question about hand reconstruction from Lewis Dingle, again, which is essentially how aggressive are you in the initial debridement and reconstruction, and do you use resurfacing techniques, dermal substitutes, etc., so that you then prevent the scarring down the line? more difficult scarring down the line?
Yeah. Well, I think, as Jeremy's alluded to, if you're dealing with a deep burn, then really early surgery is key. And what you do in that surgery is really down to your experience and your expertise. But what we want to ensure is that if there's even a tiny bit of residual dermis, then that is preserved. And you can only do that if you're using meticulous techniques with the Versajet or the dermabrader. It's much more difficult to preserve, deep dermis if you're using tangential excision. But if we have a burn where it's debrided meticulously and we've got exposed tendons, or it's all down to fat, then for sure a dermal substitute early is a good option. And but I would advise caution of doing that immediately in the resuscitation phase. So in other words, you might want to excise and temporize, and then bring the patient back once the edema has gone down to really nicely inset the dermal substitute in a good sort of position of safety for the hand. If you sort of put it on and the hand is flat on the operating table, then as soon as the patient starts moving and it's healed, it's gonna pull apart.
So final question about pressure garments. Do you use them? How often do you use them? It's quite a big commitment from patients, and they have to wear them for quite a long time. Do you think it really makes such a big difference? Is it worth it?
Well, look, the jury's still out on this, and obviously, having trained in Yorkshire and Perth, certainly in Perth, every patient that has surgery, that's my understanding when I was there, goes into early pressure. Even if they're not completely healed, most people will be in pressure by 3 weeks. And having seen the reduction in the cohort of the requirement for delayed scar intervention, I would say that definitely pressure is important, and that definitely pressure reduces the need for delayed scar intervention. Patients like it. I think it gives them a degree of security. It helps with itch. It protects that fragile scar tissue in the early phases from trauma. It helps with edema, and we know that edema worsens hypertrophic scars. So, I mean, we'll wait for the Pegasus stage 2 from Birmingham, but I think it's an important adjunct in healing.
Thank you very much. I think we'll move on to Helen Douglas now, who's going to talk to us about laser use in burn scars. Thank you very much, Alex, and welcome, Helen.
Thanks, Barry. I'll just get my screen up. Okay. Right. So thanks, Alex. Good morning, everyone, and thanks for the opportunity to talk to you about burns, related scarring, and the treatment of laser. So this slide outlines my experience with laser from my days at Canisburn with my laser mentors, Mr. Ian Mackay and Vivek Sivarajan, where I was using lasers for vascular lesions, pigmented tattoos, dermatological conditions, etc. And then a couple of degrees which involved laser in the theses, vocational qualification along the way, and then my fellowship here in Western Australia, where I learned most of what I know about CO2 ablative fractional laser from Professor Suzanne Ray, and followed on for some great work started by Alex Murray. And I've done some laser projects here too. So in short, I'm a massive laser nerd. Brief review of laser for those of you who want an overview, or those of you still to sit the exit exam. Laser is an acronym, as we know, light amplification for the stimulated emission of radiation. It was described by Einstein in the early 20th century, but the first laser was actually developed by Theodore Maiman, who was an American physicist, in 1960, using a flash lamp, a ruby crystal, and some mirrors. The concept of chromophores, so that specific elements in the tissue, such as hemoglobin, water, melanin, would preferentially absorb a specific wavelength of the electromagnetic spectrum, led to the term selective photothermolysis, which was coined by Anderson and Parrish in 1983. And what this means is essentially we can target a particular part of the tissue, for example, hemoglobin, oxygenated hemoglobin in a vascular malformation, without destroying the surrounding or overlying melanin. And that's meant that the use of lasers expanded since then and treat all sorts of conditions. The target for scars and collagen is obviously water, and that's ablative lasers over on the right-hand side of that wavelength. So ablative lasers target water and the treatment of those, particularly in scars and rhytids. You can see on the top left, there's a schematic showing the different delivery systems that ablative lasers can use. So we can use it in a full field manner where the entirety of the epidermis and a variable amount of dermis is removed, ablated, leaving what is essentially like a superficial dermal burn, which heals over 10 to 14 days. And that can be very effective for scars and wrinkles, but they're also quite high risk profiles. So pigmentation changes, delayed healing and infection, herpes infection. And so even with the good results, you can have quite high risk profiles. Now, these risk profiles were thought to be prohibitive in burns because if you don't have the hair follicles, the appendigeal structures to rekeratinize, then you're going to have much more delayed healing and huge risks of scarring. So in burn scars, ablative lasers were not particularly used, did not get popular. Then came the delivery method of fractionated delivery, where columns of tissue essentially are ablated, leaving undamaged columns of tissue in between. And this massively reduces the risk because it rapidly re-epithelializes within about 48 hours. And that means that the previous risk profile is completely changed. So you can see in the clinical photograph just below, there is the lip and the chin of the lady has been treated with full field, and then the dotty pattern, that's fractionated laser. And also on the tongue depressor on the right, you can see that there's different densities that you can apply to this fractionation. The higher the density, the more you are towards 100% full field. And some histological pictures showing the microthermal treatment zones and the undamaged columns of tissue in between. So ablative lasers can treat a lot of cutaneous conditions, and certainly during my time in Glasgow, I treated all of these, which is, acne scars, the undulating ones on the left, top left, do the best, xanthelasma, melanoma deposits, rhinophyma, scars and wrinkles, and some more unusual dermatological conditions such as tuberous sclerosis. I've boxed the scar on the bottom right because I think that, certainly in my experience, the ice pick scars didn't do particularly well with laser. They're too deep, and they're still best treated by excision and closure. But what I'm really interested in, and have been for over a decade now, is burn scars. And despite all our best efforts, you've heard very nice talks from Jeremy and Alex about early treatment, first aid, maximizing our graft take, preserving our dermis, and then reconstruction. We do still get poor scars, and then we still have to deal with them. And these are horrible scars for patients. They are thick, they are itchy, they're painful, they break down, and they're really, really unpleasant. And there's not really an awful lot of options for some of these scars. They're very large areas. You can't just cut them out and start again. So what can we do? Well, as I've alluded to, fractional delivery has been a bit of a game changer for ablative laser scar treatment. And this slide is taken from some work that I presented with Alex in 2015 at the European Burns Association meeting in Hanover. And it outlines the two most commonly used lasers for scars, which is the pulsed dye laser and the ablative fractional CO2 laser, both of which have different targets. PDL obviously targets hemoglobin. It's not ablative, it leaves an intact epidermis and heats the vessels underneath, whereas ablative fractional CO2 laser penetrates deeper and creates epidermal skin loss. Proposed mechanisms of action are listed there. Initially, it was thought to be mainly macroscopic, so destruction of the microvasculature or vaporization of water. But more studies have shown that actually there's molecular microscopic profile mechanisms going on as well, mainly involving the big players of growth factors we know about in inflammation and scar healing. So this is a review of the literature that we looked at in 2015, looking at what was out there for PDL and ablative fractional CO2 laser and burn scarring, and the answer wasn't an awful lot. But PDL had some good high-level evidence that it was good at reducing erythema and itch, particularly in the pediatric population. And the CO2 laser was showing promise in some cohort series at reducing scar volume, pliability, and texture. Updating that literature review has shown that there's actually a lot more studies out there now on both the PDL and the CO2 laser, but also on combination laser therapies, which are starting as well. So you can see that there's several really large series coming out. There's one from some colleagues over in Sydney and in the States, really showing very good results. And then the focus on a couple of RCTs, one of which was performed here in Perth. Combination laser therapy had only really just been started in 2015, but now we're seeing more and more centres using both PDL and CO2 for different targets. Certainly, if we think back to the mechanisms of action on those slides, we know that CO2 laser increases the vascular density and VEGF expression. Does that make for a larger target for the pulsed dye laser to come in and do? We're not sure yet. Do the molecular mechanisms, mainly the TGF-betas and the matrix metalloproteinases, provide a double hit synergistically? Maybe. And as Alex alluded to, there's some increasing use of laser-assisted drug delivery, which essentially means smearing some form of drug or product onto the channels of perforated scar and seeing if this will penetrate into the scar and do some treatment. So topical steroids are very common, but there's been some work doing RECELL cell-based therapies, and now there's some more laser-assisted drug delivery thinking about molecular studies and gene therapy. So watch this space, really. So what do we do? Well, here in WA, we use the ablative fractionated CO2 laser, and using the settings shown, we use it every 6 weeks in sets of 3 treatments. And why? Well, Alex helped set up the laser service here in Western Australia in 2014. And what we know about the laser has increased massively, but even using it then, we found that there are aesthetic and symptomatic improvements when we use the CO2 laser on burn scars, particularly in terms of itch, which, as most of you know, can be very, very problematic in burns patients. We also noticed that there were some significant functional improvements. So this is a patient of Alex's who, after only 3 treatments of the CO2 laser, had a real increase in the range of motion of his axillas, as well as a reduction in the vascularity of his scar. So taking these observations, my colleagues, Prof. Ray, Prof. Wood and Alex, designed an RCT to investigate what we saw. And what it did was it looked at the scars at least 6 months old, with a VSS score of over 5 and at least a 10 centimetre square area. And it randomised that scar to a particular vector design, and then the half of it was either control or treatment. The treatment area received 3 lasers 4 to 6 weeks apart using the luminous ultrapulse laser. We also looked at baseline and 6 weeks post-final treatment, some clinical scar scores and histology. And when I started my fellowship in 2016 here, I managed to track down half the patients, and in addition, looked at those parameters 2 years post the final follow-up. And what did we find? Well, we found that there were some significant improvements in the itch and pain in the treated scar segments. We found significant improvements in dermal collagen architecture in terms of the thickness of the collagen fibers. And then when we looked a bit more closely at the patients, we found that all of the significant results that we had gathered were in the immature scar group. So patients that had had their injury between 6 and 18 months before the laser. Whereas the more mature scars, we saw a trend to improvement, but it wasn't significant. So does earlier intervention for laser mean that we can improve the scars more? That's what we were proposing. So here's a picture of one of our immature scar patients at 6 months post his injury on the top left, and then that's his pre-laser, and then 2 years post his final treatment on the right. And then if we look specifically at the infra-umbilical area, which was his scar segment, the treatment zone was the bottom right diagonal. On the left is our baseline pre-treatment. In the middle, it's 6 weeks post-final treatment. And on the right, it's 2 years post-final treatment. And you know, it's very difficult to assess improvements in scars, particularly segments, when you've got such a global improvement in scar. Interestingly, we did not find the VSS very useful for this. The VSS did not pick up any difference in our scars from start to 2 years post-treatment. And we don't know if that's because it was over a long time, we used lots of different raters, but we didn't find it particularly sensitive to pick up what was obviously an improved scar anyway. This is a picture of one of our mature scar patients. She was burned as a child and received some skin grafting, and the picture on the left is her pre-laser therapy, and on the right is after 3 lasers to her leg. She's obviously in the mature scar group, and she thinks that it definitely improved her scar, both in terms of how it looks, the pliability and the feel. And I agree with her, but we haven't been able to show that. And I think this is one of the challenges of research in scars. It's difficult to prove improvement. We've also done some work regarding the timing of laser. I saw there was a question about that. So when would you start the laser? So previously there's been lots of using the laser when we've got established thick hypertrophic scars or when conventional methods haven't worked. What we found when we were doing this is that we've started using the laser earlier and earlier. So this is a child who had a 23% scald, early surgery, was healed very early, but still had very thick scarring 9 months post his injury. He had 4 laser treatments over 8 months and got a good result. Here's another teenager who had a very nasty active scarring early. He was debrided and grafted and healed quickly, but very thick scars at 6 weeks. So we started his laser just prior to 3 months post-injury, and he had 3 laser treatments. And you can see on the right, his scars are a lot flatter and less vascular. And he still needed nail fold releases and a Z-plasty to release that first web. But it made it a lot easier rather than cutting through what was essentially bleeding concrete. And so we found it a really useful adjunct doing some early laser. We've also reviewed our pediatric hand burns. So this is a group that we find particularly challenging. So the injury literally and the problem grows year on year. You've grafted a hand and you then need to release it as it grows. So we had a look at all of our data, and then what we found, looking back, was that since we've introduced the laser, we've had less reconstructive operations performed. And also the time between these reconstructive operations has increased. Very indirect measure, not without its biases, but we propose that it might buy us time between these reconstructive procedures and might even reduce the overall number required. So to confirm this, we're going to look prospectively. We're building our database and we're using some 3D cameras instead of goniometers so that we can look at ranges pre and post laser, and hopefully we'll be able to answer that soon. So some cases to illustrate: it was a very nasty campfire burn to a pair of hands. Obviously needed debridement and grafting early. And here she is on the left, having 3 years post her injury, but still quite mature hypertrophic scar. And then on the right, after 3 lasers, it's not perfect, but it's improved it, and bought us a bit of time before her next graft release and reconstruction. And here is another example. It's a young girl who had a very mature hypertrophic scar, 5 years post-injury, but no one would hold her hand at kindergarten, because it felt lumpy and bumpy. So we did 3 lasers and it flattened it off. And I think that the laser definitely does improve mature scarring, but it's difficult to prove. We need to do that. What are we going to do going forward? Well, we're updating our paediatric hand database, as we've said. We'd like to compare some laser modes, and one of the benefits of being in touch with people like Alex is I can see what she's doing, what works, and she tells me that she's getting some really good results with scar effects. So we're going to do some protocols about comparing those with deep effects. And we've also taken what we learned from our randomized controlled trial and redesigned another. So we've just finished our data collection for the ELLIPSE trial, which is the early laser intervention promotes scar evolution, which looks at bilateral burns, 1 on each limb, one of which treated the same, one randomized to 3 laser treatments starting early at 12 weeks, and the other one standard care. And we have finished our data completion on that, and our most recent fellow, Chris Lewis, who's now working in Newcastle, is helping us with this. So we should be able to have some results for you soon. Okay, thank you very much for your time and listening to all my laser waffle.
Great, thank you so much, Helen. The fire alarm here has stopped, which is good, and we're still all alive, and that was really fascinating. There are quite a few questions again, but if I'd just like to kick off with a question about the type of laser. Clearly, ideally, what you want is an ablative laser. That seems to have the best evidence. But what if a centre can't access that kind of laser? Is there any use for something like IPL, for example?
So I've used IPL, but I think that its use for burns is limited to just erythema reduction, and it's quite superficial. So because it's essentially not a laser, it's a filtered light system. It's got nowhere near the power, which is why it's so much more commercially available. And I think it's very good for treating things like rosacea or superficial erythema or superficial pigmentation such as lentigo. But I don't see its application for anything that's thick, deep scars. Maybe a bit of dyschromia, perhaps. But I think to maximize that scar remodeling, you need something that's going to ablate down in to get all of those molecular effects that we see.
Yeah, that makes sense. And in terms of addressing hyperpigmentation with laser, how do you use it? What settings would you use, etc.?
That's a good question. So if what's very easy is if the patient is very, very pale with a dark scar, you can use a tattoo laser, as Alex said, like the ND YAG, but that's pretty rare. What we usually find is the people with type 3, 4, 5 Fitzpatrick skin with the dark scars. And then, I'm very cautious because you can take a dark scar and make it white. And I would say that looks worse. We've had some improvement with, and I think it comes back to that risk-benefit ratio that Alex was talking about. We've had some improvement using the CPG handpiece, the ActiveX FX, which is a more of a scattering profile blending on lower settings, sort of 9 watts kind of thing. But I've been very cautious and been using them in small patch test areas first, and re-reviewing and going up very incrementally. Alex, have you had much use of the CPG?
No, I mean, we've used, thanks Helen, that was a fantastic talk. We've used the ActiveX similar to you, I think, just, test patch areas and work up incrementally, because as you correctly say, you don't want to convert a hyperpigmented scar into a hypopigmented scar. And I think the dermabrasion technique is more reliable for those cases.
Yeah.
Thanks very much. There's a question about how you modify your laser, if you even modify your laser for different skin tones.
I would start, so we've selected our settings carefully. When I say we, and I mean Alex and Suzanne did a lot of work in this very early, and you know, Jeremy. We've selected our settings based on what we experienced, and we're now expanding and looking like everyone else is at what everyone else is doing. But I think that the two things would be density and power, because the more dense you make your fractionated columns, the more you're looking towards a full field, and that's when you're getting towards the slower reepithelialization, and that's going to reduce your pigmentation, increase your risk of pigmentation problems. So I'd say with pigmented skin, I have used it, but I've gone low density and started on low energy, and then again just gone up from there. And touch wood, I've not had too many problems, and it's always been scars that have benefited from the reduction in height and pliability, and I've not seen much in the way of hypopigmentation using the fractionated low density settings.
And now that we live in a COVID world, is there any sort of extra precaution you would take? Presumably these are sort of aerosol generating procedures, or at least they're creating plumes. Is there anything you do extra apart from the usual masks and visors, etc.?
We've got an extraction device that removes particulate matter, obviously the risk of bloodborne, you know, diseases, transmission, and the risk of, you know, the equivalent of smoking a pack a day, wasn't it, from the plumes of smoke that we have in theatre. But we were certainly, we wear N95 masks as well. Now those were very recently nowhere to be found. So we stopped doing all lasers during the COVID-19 episode. We've recently recommenced because PPE here has no longer been restricted. But yeah, you need to have good filtered masks, otherwise you risk your own health.
And do you test, or when you restart, if you restart, will you be testing patients for COVID?
We haven't been testing them routinely. There's been talk about testing health workers and children randomly to look at our community transmission. But no, we haven't been testing patients because we've had so little community spread. Thanks very much, Helen.
Great. Well, thank you to all the panelists. I'm just going to. Oh, you're not okay. Thank you all for a wonderful overview of burns, acute management, and scar management. I think it's been incredibly educational for all levels of plastic surgery trainees and consultants and beyond. I think it's a great connection we have with Perth and Aylesbury, and I can see that connection is going to continue, and hopefully there'll be more collaboration and research together. So again, thank you Jeremy, thank you Alex, and thank you Helen, and hope the rest of you join for the next Icoplast webinar.